Dr. White for coming today. Dr. White attended Temple University School of Podiatric Medicine and completed his 3-year surgical residency at Graduate Hospital in Philadelphia, as well as advanced training in diabetic limb salvage, ankle arthroscopy, and use of external fixation. He had been practicing up in Lewiston for the last 10 years and has been down here at Portland Foot and Ankle for the last 2 years. So I had asked Dr. White to help us understand the foot a little bit better, and so he was kind enough to come up with a top 10 list of all the things that we need to know to address foot complaints. So take it away, Dr. White.
Great. Thank you. Well, thank you for letting me come to it. It's been about 2 years. I came in May of 2014, so and it's been a great move for a lot of reasons, family, work, everything. But I was in Brunswick and Lewiston for 10 years, and I had some good times there, but this has been a very good professional move for me as well. I was talking to him earlier about we're in the process of building a house, which isn't going so well, but we're definitely still here in Maine to stay, so we're not going anywhere. A lot of you I know, I've been talking to you, but I always throw this slide in there for the ones I don't because I know you're all thinking it, but as she said, I actually grew up in New England. I grew up in Braintree, south of Boston, went to Springfield College, and get out of here. Get out? Oh my gosh. So you know, I'm from Holbrook, but I never say that because no one knows where that is. And I do live in a rental right now in Yarmouth, but we're building a house in Yarmouth. So as she said, I thought it'd be good to just kind of go over a top 10 list. I used to love David Letterman's top 10. Not to say that this is the only 10 things we see, but I think this is a pretty good list of things we see on a daily basis. I'd be remiss if I had to talk with 10 things and didn't talk about this. We see these every day. I did 2 this morning. You guys see them and send them over, which is great. Patients present generally with pain, redness, swelling in that area of the toe. It's more common medially, and what's interesting is that it's actually more common in people that have a flat foot because they have an apropulsive gait, so they twist off that great toe, which puts more pressure on the inside of that medial border. They usually present saying they've tried to trim it or they've been doing this for years. You've heard the story, and eventually the pain and inflammation gets to the point where they seek treatment. Oral antibiotics, often from the primary care. Temporize it, help for a little bit, but doesn't solve the problem. With these, you really have to get in there and remove the nail. So I say bathroom surgery. That's sort of our term for patients trying to, get their foot up on the toilet and try to trim it, and they never will get it. And I'll show you why they'll never get it. So generally, we tell people you have to remove the nail. How you do that can vary. So you can do a temporary partial, temporary total. You can do a matrixectomy. That can be with phenol. Or what I do a lot of times is I'll excise the root of the nail itself, so a surgical matrixectomy. But if you look at this procedure here, you see that sort of margin of nail. And if you look at that piece of nail, it doesn't look like you're taking out that much. But if you see when I turn that nail out, how much nail was actually underneath that skin. And that's why the patients are never going to get that out. I don't care how tough they are or how much they dig. They're not going to get that corner. And, in fact, when they get a lot of it, they leave a little piece in the back, and that's the worst-case scenario. So these need to be seen. And these are cases where if you guys have a patient that comes in and it's really bothering them, just send it over. I mean, these are acute cases that we can do in half an hour, 20 minutes, and, get them better. So case 2, chronic plantar medial heel pain. Now, you see this, I'm sure, a lot. I see it. Again, I saw 1 or 2 of these this morning already. They come in with an insidious onset, so usually it's not related to any type of trauma. That classic post-static dyskinesia, so that pain first thing in the morning, that's what they all say, or if they sit in the car for a while and go to get up, that's generally when they have the most symptoms. This is a patient that actually had bilateral pain that came for a second opinion, had been treated for 12 months with everything under the sun in terms of conservative care, physical therapy, cortisone injections, night splints, orthotics, acupuncture even, and she was very upset that she was gaining weight due to inactivity. So this was a case where surgically we actually went in, and I'll talk about it later, but surgery is indicated in about 1 out of 10 or 10%. So we don't do surgery on every patient that comes in with plantar fasciitis. This is a different case where someone had symptoms for 12-plus months, and we ended up doing a bilateral instep. So you probably see patients that have had heel spur surgery or plantar fascial surgery. The way I do it is with this small 2 or 3 centimeter incision. I like it better than the EPF, which is the scope. The scope Obviously, you don't see much other than what you see in, through the scope, and that's very limited. This is a great visualization of that fascia that you can then resect. The problem has always been with these, if you look at the intrinsic musculature, so if I go back and I show you that's the fascia there, once you transect it, you see the muscles underneath it. The problem is they scar down. So what I've been doing recently, I'm using an amniotic graft, which is it's a sort of a newer thought. Maybe there's been talks on this in other aspects of medicine, but we're using it a lot for scar tissue and burns and wounds, and this has worked great for, you know, both getting it to heal quickly and also to prevent scarring. So here's a patient that we did, again, bilateral. I generally space them out 3 months apart, so that's 1 month on your right there, and or I guess your left, and 4 months on the right. You can see the difference in terms of the skin, but because it's a transverse incision sort of in line with the skin tension lines, they heal very well. You almost can't even see that. So again, evaluation, these aren't all plantar fasciitis. Occasionally you get tarsal tunnel. I usually send patients for EMGs or NCVs to confirm that. Problem is sometimes EMG NCVs are negative, but in the absence of any other diagnosis, I often go in and do a release, and patients do pretty well. This picture I want to show you, though, because I get these patients all the time. These are the hardest patients to talk to. They come in saying, I've got a heel spur, you've got to take it off. I've been in practice 12 years. I've never taken a heel spur off. It's just not indicated. The only time a heel spur needs to be removed is if that spur that I showed, and that's a pretty big spur. If that's plantar prominent, if that's actually going downward, that would be an indication to remove it. But again, I've been in practice 12 years and I've never seen that. So generally spurs are just a sign of pull on that area for years. Plantar fasciitis is still the diagnosis. And if they need surgery, which it doesn't happen all the time, about 10%, it's a fascial release, not a heel spur resection. So again, differentials, tarsal tunnel, that's a tarsal tunnel release there. Patients do very well with that, similar to a carpal tunnel, although we do them all open. Entrapment of the first branch of the lateral plantar nerve, radiculopathies, calcaneal stress fractures, but these are very, very rare. Again, treatment for this, generally conservative, 0 to 3 months, NSAIDs, prefab, orthotics, stretching, night splints, icing, cortisone injections, and greater than 3 months, we get into some of the custom orthotics, PT. Advanced biologics are things like PRP, you've heard of those. Amniotic tissue is sort of the newer version of that. And then we get into discussing surgery. But remember, 90% of these people don't need surgery. They do fine with conservative care. I'm going to get right to there. All right, submet 2 pain. This is, again, one of the most common things I see. So this patient presents contracted second toe, although not terribly contracted, plantar forefoot pain, so submet 2, right underneath that second metatarsal phalangeal joint. They generally get pain at that dorsal IPJ from shoes. A lot of times with these, they've had a bunion, they've had a little bit of a hammer toe, but all of a sudden it gets worse. And I saw a patient last week, very same case, this isn't her, but all of a sudden it really starts to be painful. They get increased submet 2 pain, and that second toe starts to drift. And again, usually they have a bunion that goes along with this. So if you look at these x-rays, you see that lateral, how that second toe is sitting up in the air. The reason it's sitting up like that is the plantar plate, which sits, I don't have a pointer on here, but basically the plantar plate sits right underneath the second MPJ. That over time gets weaker as you start to have a hammer toe, and the progression generally is the bunion or the hallux valgus, the big toe drifts laterally. It can go under or over, but usually it goes under, and the second toe starts to pop up, and as it starts to pop up, the plantar plate starts to fatigue, and eventually it tears. Once it tears, this is a surgical type of case because there's no way to get that toe to sit back down. We can try splint and taping, but it just doesn't work. So again, remember, it's a plantar plate injury with these things. Can be chronic just over time, fatigues and tears, or it can be an acute event. So what you do with these is you've got to address the bunion because you can't address the second met without addressing the bunion. So you have to address the bunion with a typical osteotomy, reposition the hallux, shorten the second metatarsal. If you look at a pre-op x-ray, see how that second metatarsal is a lot longer, certainly than the first, but even the third. That predisposes these patients to predislocation syndrome, plantar plate injuries. So one of the things you want to address is you want to shorten that. Because the metatarsals are declinated, just like my fingers here, by shortening it, you actually elevate it too. So that's getting it off the ground, which is going to make them feel a lot better. And then you reduce the second toe. Now, in a case like this, we call this sort of a hammer toe, although as you see, I didn't really fix the hammer toe. I didn't put an implant or a pin in the toe because I didn't need to. There are cases where the toe contracts over time. So if in a patient like that, if she just doesn't seek any treatment or seeks someone that doesn't recognize that and comes in 6 years later, now the toe is going to be buckled, and now we've got to address the second toe as well. So treatment options, again, that's a surgical case, but they're not all surgical. Extra depth shoes, depending on patient's activity and age. Sometimes there's a callus, you can simply debride that. Orthotics are options, boot and splints or splints to hold the toe down, and little gel pads sometimes help on these patients. Surgical tenotomy, capsulotomy, you can do that right in the office. That's essentially when it's a relatively flexible deformity. You can just do a plantar tenotomy either with an 18-gauge needle or a 15-blade, and patients do really well with those simple procedures often. Arthroplasties by taking a section of the joint out, which I'll show you. Tendon transfers you can do, again, as long as it's flexible. Arthrodesis is really the gold standard, and that's basically fusing that toe. Years ago, it used to all be with K-wires. We don't really do those anymore, and I'll kind of show you why. And the adjunctive procedures, while osteotomies, plantar plate repairs are kind of where we're at now surgically with these. So if you look at a fourth, fifth toe hammer toe contracture, these are very common. The fifth toe is impinging on the fourth. They generally get a callus right in that fourth interdigital space. And these calluses hurt. I mean, they're painful. I have patients that come in and want me to amputate that toe because the callus hurts so much. And we always treat them conservatively. So again, extra depth shoes, debridement of the callus, gel padding. But that doesn't always do the trick. So occasionally we'll go in and we'll do a reduction. You see the implant in that fourth toe, essentially repositioning that that fourth toe, and then instead of a K-wire, which is what they used to use, which patients hate, we use these little interdigital devices that sit inside and fuse that joint without anything sticking through the skin. And then the fifth toe, we do an arthroplasty, where essentially you just remove section of bone, but you don't put any fixation through there. You really don't want that fifth toe to be dagger straight. You want to have some mobility because of shoes. That shoe lateral board is going to push on that fifth toe. So occasionally I still use K-wires. There are times, not very often, a case like on the left there is essentially you need a pan-metatarsal head resection rheumatoid patient. And with those, you really still need to use K-wires. But on the case on the right, which is still a pretty bad forefoot deformity, very bad bunion, dislocated second MPJ, hammer toe contractures across the board, I was able to do this without any K-wires, which again, patients love. Not only do patients like them, but they lead to a better fusion because at some point you've got to take the pin out and now you've lost your fixation, and that can be a week after surgery or it can be 6 weeks after surgery. So these interdigital devices are much more efficient. Here's a bunion, again, long second metatarsal. This is a case where the second toe was contracted because this was something that went on for a while. So you fix the bunion, decompress the second met, and then toe implant for the second toe. And again, very important that you get that fusion, because if you don't get fusion, they're going to get chronic pain at that site, and they're going to get motion, and they're going to be very uncomfortable. And I'm sure you guys see patients in the office that have had surgery that are not happy, and that's generally the reason why. So here's a case. This is a terrible bunion. Well, I gave it away. It's a bunion. But this patient comes in, an older lady, progressive pain, submet 2 pain, more pain submet 2 than on the bunion itself. Can't wear shoes, can't walk. And again, this patient asked me if I could amputate her toe. Now, you never want to amputate a toe if you can avoid it, because if you amputate the contracted toe, the other toes are going to drift into that space. So that's usually not an option. In a case like this, though, with the severity of the bunion, there's a couple options. One, you can do a double osteotomy of the first met and then the great toe. But now you're asking this patient, I think was in her 70s, to heal 2 osteotomies, and even at that, maybe not able to reposition that perfectly. So in a case like this, what I do is a fusion. And initially it sounds aggressive, but I got to tell you, these work the best. You can look at her reduction. It's one procedure. We use pretty robust fixation, so that's a big locking plate with a compression staple, which is nitinol. So essentially nitinol staples, they're always going to want to find their resting point, which is compressed, but they go in at a right angle. So as soon as you put it in, it starts to compress, and it wants to compress forever. So it's it's sort of a new technology, but they work great for things like this. But again, here's a case where it's a severe bunion. And really, the option with that is the best option I feel is to fuse that joint. So bunions, I get this question all the time in the office from patients and even from other docs. Well, why did so-and-so have a bunion and she was walking 2 days after surgery, no pain and all sort of stuff, and the other one, you know, you did the same one, she was off her feet for 6 weeks. Well, it's because all bunions are not created equal. They vary for a lot of different reasons. If you look at all 4 of these are all very different, and the procedures are all very different. If you look at the first one, this is a gentleman with just a pretty standard bunion. These are painful. He did have a little fracture fragment on that medial side as well. But these are pretty straightforward, as straightforward as bunion surgery can be. It's a distal osteotomy. It's a sort of a sideways V. Initially, when they developed it, they used to float them, meaning they didn't fix them at all. Today, we use, compression screws to hold it. And we basically let these people walk right after surgery. It takes bone 4 to 6 weeks to heal, and then they're back in their shoes. And they generally do so predictably well. Here's a case where obviously this is a lot worse. This is a very bad bunion. It's a dislocated second toe. What are your options here? Well, you can do, again, double osteotomies. You can do Lapidus, which is a fusion. This was an older patient, though, that I didn't feel like would do well with a Lapidus. Lapidus, which I'll show you in a minute, have about a 10% non-union rate, and that's in best cases. So you want to be careful when and who you do those on. But here's a case where I did a long arm Austin. So what that means is that instead of a sideways V that's 60 degrees, you make the dorsal arm really long. And with doing a long arm, I can shift that head a lot more. And you can see the correction is pretty good there. Not perfect, but pretty good. And we also did a decompressive second osteotomy to bring that second metatarsal down and relocate that toe on top. This is just another type of toe implant that we use to fuse that joint. They all work pretty similarly. Again, here's another pretty high angle bunion. This is a younger patient who really wanted that IM to be back to neutral, so we did a Lapidus on her. So a Lapidus is, again, that first met cuneiform, that joint proximal to where the first MPJ is. And the way we do them now, at least the way I do them, is pretty robust fixation. So that's a locking plate with a compression screw that puts that together very tightly. So even though I say there's a 10% non-union rate, I'm probably jinxing myself, but I don't get them that much of the time. And I think it's a lot to do with the fixation. But you can see her IM correction's pretty good. I mean, the goal is to get it down to about 0 to 2 or 3 degrees, and I think that's right within that range. And at the same time, we did a second met osteotomy because a lot of times with a bad bunion, the first met drifts medial, but it also drifts up in the air, and that creates a lot of pressure on the second met. So we shift the second met back and up as well. So here's even a worse bunion, which was also a Lapidus. And this patient did great, but had fixation pain, which can happen. So we took the fixation out just a few weeks ago. She's doing very well, asymptomatic. So I put this up there. I've hit 2 deer this year. I haven't hit a moose, but this is a crazy picture. This person actually walked out of that car with no injuries, but they are big animals, aren't they? I was up in Rangeley last year, and I almost hit a moose. But, yeah, that's pretty crazy. All right. Any questions at this point about anything? No? All right. Correlation with the moose? I just thought I'd throw that in there to ask any questions yet. No.
When is the ideal time?
Age, or you mean like an age of a patient, or? It's hard because sometimes people come in and they have a mild bunion and it really bothers them, and I usually talk to them about options for fixing it. And then some people come in and it looks ridiculous, but it doesn't hurt them, and I say, just, it's fine. I don't ever push surgery, so I don't think there's an optimal time based on the degree of deformity. It's really just symptoms. Yeah.
Sorry. What's the recovery time for fusion of this?
First MP, the hammer toes?
Well, for like what's the
So they vary a little bit. So for the hammer toes that we talked about with those little implants, usually by 4 weeks they're pretty solid, and I let people start walking. MPJs, we'll talk about in a little bit. They're usually 3 weeks non-weight bearing and then 7 to 8 weeks of protective weight bearing. Lapidus, same thing, 3 weeks non-weight bearing, probably another 8 weeks of non-weight or partial weight bearing. So that's an issue that you always have to talk about with patients, because the worst thing to do with any of these is decide to do surgery and then walk all over it, which I see, and then they're in a worse place than they were to start. But yeah, first MPJs we'll talk about actually, I think, right now. So this is a classic first MPJ arthritis, which is the most common form of DJD in the foot. We see it all the time. This was an interesting patient who actually found me via an internet search because she knew I did this type of procedure. Progressive symptoms for years, altered biomechanics. So what happens when the first MPJ is you see the spurs on the lateral there, they can't move that joint at all. Normally that joint for normal mechanics has to extend 65 degrees or so and plantar flex about 15 degrees. And when it doesn't, the gate's abnormal. So you either have to turn your foot to the side or walk on the outside border of your foot, or you come off your toe early. So it starts affecting your knee, your hip, your back, everything else. So they're definitely conditions that we want to look at. But this patient did not want a fusion, had done her research and knew that sort of the gold standard for arthritis is to fuse the joint, and did not want a fusion. So she wanted to do an implant. So these are newer implants that we're using that I've done 4 of them now, so it's still a relatively new thought. But they're called a hemicap, and essentially they're a new version of an old implant that used to just be a flat front surface with nothing on top. And that new, what we call dorsal flange on top, is really, in my opinion, what makes this a winner, because you don't get the scar tissue on top of the joint like you used to. So the goal with this is obviously to keep the joint moving, but to remove the surrounding spurs and the damaged cartilage. And here you can see this is her post-op. The implant's positioned very well, and she's got pretty good range of motion. I mean, it's not 65, but it's probably in the area of 40 to 50, which is acceptable, so much better than her pre-op, which was about 10. So that's one option for these arthritic joints. We'll go right through that. But when I look at these, there's a lot of stages. I think there's 5 there, but this one here is what I use. If they come in and there's mild to moderate spurring, functional limitations, so they know they don't have the normal range of motion, we usually treat them conservatively. Orthotics, you can either do a first-rate cutout, which essentially, if it's a very early stage of the disease, lets the joint function maximally, or if it's towards the end of the grades, you can do a Morton's extension, which is just a flat, rigid sole under the orthotic, so that joint doesn't have to flex when they walk. But certainly for grade 1 and even some 2, we try conservative care, and oftentimes it's effective. Grade 2, moderate spurring, and you see these, they get these big spurs surrounding the joint, and they're starting to get pretty restricted range of motion. Grade 3 are end stage, where they almost have no motion, but it's very, very painful. Conservative treatment, like I said. Cortisone injections I put up there, although they don't work very well. They hurt like heck. Because you don't have a good capsule there. The ankle has a good capsule. The knee has a good capsule. The first MBJ doesn't have a great capsule. So cortisone injections are very painful to try to get into that joint. They just don't work well. The padding, the inserts, PT, sometimes. Generally, it's telling them, listen, modify your activities, and that'll probably help. Surgical treatment, there's a lot of options. Joint preserving, so chilectomy, yeah, that guy's kind of crazy. Chilectomies are what I do, and I'll show you one of those, and they work, I would say, 80 to 90% of the time, depending on the level of disease. OCD repair, microfracture, newer thoughts, kind of like they do in the knee, don't work all that great, in my opinion. Osteotomies to sort of realign the joint. And then you're really looking at implants, resurfacing procedures, and fusion. If you look at a chilectomy, so this is a classic first MBJ arthritis, I'd say grade 2, which is mostly what I see. If you look on the right, you see the spur, the lip on that proximal phalanx. You see the spur on the first met. And it's no wonder that joint can't move, because those 2 pieces of bone are jamming into each other. So it makes sense to just simply go in and try to remove those. The problem we have to tell patients is that even though I can do that, I can take that spur off, I can't do much inside the joint. There's no way to really decompress that area without doing a fusion or an implant. So you're limited in terms of the disease, how bad it is inside the joint. So you see the spurs preoperatively on top. Well, they're easy to take off. You just go in and simply run or take a saw and remove those. And you get, therefore, better range of motion. But with this case, you still can't affect that intra-articular disease. Yeah, there's a lot of compression. There's almost bone on bone dorsally. This patient is doing well right now, but there's always a chance that they start to regress, and then they need something like a fusion or an implant. So again, that's post-resection. And what I do, again, I'm using a lot of that amniotic tissue. I actually apply that graft to that dorsal surface, because one of the problems with that resection site is things want to scar down to that. So this is a great barrier to prevent some of that scarring. But as you see with Easley et al., 90% satisfaction rate at 5 years post-op with chilectomy. So if they're done in the right patient, they work very well. But fusions, they're the gold standard, and they're hard to tell patients this because no one wants to fuse a joint, especially in their foot, but patients do very, very well. This guy comes in, this is a carpenter actually, who had a terrible, terrible joint, as you see, almost no joint space, dorsal spurring, and needed a fusion. And he was reluctant. I told him I could fuse it up a little bit. So if you see that I bent that plate a little bit on purpose so that I can pull the toe up, because if it's dead straight, they can't crouch down. Women, for example, we oftentimes bend the plate so they can wear a little bit of a heel if they want to. So this guy bent the plate a little bit, and he's done really, really well. He went out to fuse perfectly. Here's a post-bunion that gets arthritic. So same thing, gold standard is to fuse that joint. So the bunion correction didn't work, and went in and did a fusion, and she did really well. She actually walked all over this. Like, talk about non-weight. She wasn't non-weight bearing for a day. She was a nurse practitioner up in Lewiston, and it still healed somehow. I don't know how. So here's I see these all the time, too. Generally, I say this patient, 6-year-old active female, denies any injury, pain, swelling with walking. You take initial x-ray, and you see that, which is really nothing, right, or is it? If you look a little closer, you start to see that little fluffy periosteum on the second metatarsal medially. And if you look at it a week later, now you start to see that stress fracture. So we see these all the time. And in fact, when I see these back here, even if I don't see anything at all, I still diagnose them with a stress fracture because I can tell clinically that it's happening. X-rays take a while to show up that bone turnover. You could order a bone scan and all these other crazy expensive tests, but you don't need to. This is a classic stress fracture. They can take a long time to heal, though, especially in patients that don't listen, and a lot of these don't because they hear stress fracture and they just don't, they don't add it together that this could be a major problem. They walk all over it, and it can take a long time. But you see this progression. As it's looking worse, it's actually getting better because that's bone callus that's stabilizing that fracture site. But the key is you got to immobilize them, and if you're having trouble with it healing, get a bone stim. So here, in line with a stress fracture, here we see this college athlete that was actually a rower that came after an inversion ankle injury, and she was actually evaluated up at Penn Bay and told that wear a surgical shoe and you should heal in a few weeks. No way. If you look at this fracture, I'm going to show you a little bit more, but that angulation and that fragmentation is terrible. And this is a young patient. I mean, this patient's in her, I think she was 20. So this is a case that these need to be fixed, and the way you fix them is with a large plate. And if you get an interfrag screw, if you see that frag screw on the bottom of the plate, just like an ankle fracture, you want to get that in there to hold it together and then plate it to make it solid. But these really need to be fixed. If you look at, you hear a lot of, well, do fifth metatarsal fractures need to be fixed? They don't all need to be fixed. Avulsion fractures, super common. I very rarely fix those. You got to immobilize them, though, because the peroneal tendon pulls on that fragment. So they need to be in a cam lock or air cast. Jones fractures, depends on the patient. Jones fractures are at the proximal diaphysis, so towards the base. Not this is a diaphyseal fracture, but Jones fractures are in an area where the blood supply is terrible. So in older patients and in patients, sometimes elite athletes will fix them right away to prevent that potential non-healing or non-union. But Jones fractures are still sort of in that in-between. Diaphyseal fractures almost always, in my opinion, need to be fixed. So that was another one. That's a separate case there that we went in and plated. And it just gets the metatarsal in a better position. The problem with leaving these is it may heal, but because of that angulation you saw, they end up walking on the distal fragment forever, which is never comfortable, and they end up having either some type of nerve issue down the road or end up having to reposition metatarsal later on. Chronic pain, swelling, lateral hindfoot. This is another thing I see a ton of. Interestingly enough, I haven't seen it as much here in Portland as I did in Lewiston. I don't know why, but I may just not be getting referrals for it. But this is a classic sort of post-ankle sprain injury where they're not getting better. So months of PT, ice NSAIDs, episodic pain, edema just persists. They're unable to get back to their normal activities. And essentially what happens is there's a tear of the peroneus brevis. So there's two peroneal tendons. Brevis sits, as you see there, longus is sort of tucked behind it. Brevis very routinely tears at the peroneal tubercle, and even MRIs often are negative, but these patients present with pain right kind of where I have that star on the skin, and it just doesn't go away, and it's there for months and months and months. So what we do is we go in, and what you'll identify is that tendon doesn't look great, right? If you look at the longus, which is the tendon behind it, the white one, that looks healthy. If you look at the brevis, it looks terrible. It's flat. It's attenuated. So what we do is we ellipse out that area, that purple marker, essentially just take that double ellipse right out, and then we retubularize it, we call it. We essentially, wrap that tendon back to the sort of normal anatomy. And there's another case where I use grafts to sort of help scarring. Minimal pain, minimal edema, minimal inflammation. These patients do very, very well, very quickly.
Right, I think that would come with doing lots of them. Okay.
Yeah, so you take out, like not full thickness, you just take out that area that's, sort of diseased or striated, and then you take the good tendon and kind of roll it back together. Yeah.
Roll it back together like he ties. And then he ties the rest of it together. That's going to be.
This is just, so in line with peroneal tendon pathology, oftentimes you get subluxing peroneals, so patients will come in and say they feel a clicking in their ankle, and usually that's not an ankle sprain type injury, that's a peroneal subluxation. And the reason that happens, if you look there, the lip of the fibula cuts into that brevis tendon. So again, the longus is underneath it, the brevis is right in the groove, and generally it tears that brevis in two. So here's a case, subluxation, kind of right mid-substance. And general rule of thumb is if it's greater than 50%, take the tendon out and tenodece it, or basically tie those two tendons together. Or if it's less than 50%, you sort of repair it. And here's a case where we just did the same thing. We took out the diseased portion, retubularized it, And then very importantly, what you have to do is you have to tuck that tendon back underneath that lip and repair that, what they call the superficial peroneal retinaculum, because if you don't do that, it's going to keep popping out. You're going to be worse than you were to start. And again, that's a repair of the SPR. So we're doing okay. This is, I almost put my spider bite on here. I really did. I was going to put that up there, but I think we don't even know what it was. But this is my other camp story. So my son, who loves to fish, my daughter, who doesn't like anything anymore because she's a teenager, but she used to like to fish. And last year, my son was practicing his cast, and he caught Dad. And this, I got to tell you how painful this was. So this, it's like 6 in the morning, and I went in to see if, I couldn't get it because it was right in the small of my back. My wife, who, she says she's retired, but she's a nurse, and she tried to get it. She couldn't get it. She was yanking it. All 3 prongs were in my back. I had to go to the Augusta. I felt I was embarrassed. I walked, that's me at the desk. Like, I said, I have a hook in my back. And they said, no, you don't. So I turned around, and I did. All right, so we got 10 minutes left. Perfect. So we have 2 more cases. So non-healing chronic ulcers, again, this is another big part of my experience and my practice. I'm hooked up with St. Mary's Wound Center. North Conway has been sending me a lot of patients. In fact, that's where this one's from. MayMed is starting one. I'm not quite sure how that's going, but I know they're starting one, and Mercy has one as well. These are big deals, and these are cases that I wouldn't say I love, but I've been happy treating and getting these patients walking again. But here's a patient, neuropathic diabetic. He's got palpable pulses. He's got a chronic wound, 9 months. Wound Care Center, North Conway, for 6 months of advanced, therapeutics, all these grafts and these things you hear about that are super expensive. IV antibiotics, because what they did is in the wound center, they took a biopsy, which I never like when they do that, going through the wound, because you're going to get something. But they took a biopsy. It was MRSA, so they put him on IV antibiotics. You've heard these stories all the time, right? They sent him to me for an amputation. They thought a TMA. And I looked at it, I said, no way is that a TMA. So here's a case where you look at the bone. It's hard to tell from that, is it osteo, is it not? Probably based on the chronicity of the wound, it is. But I wasn't super impressed with the x-ray. So classic workup, regardless of who the patient is, assess the blood flow. Again, this patient had palpable pulses, but if they don't, PVRs, TCOMs, 8 gram if necessary, make sure there's blood supply there. Is there infection? Is there not? Is it bone infection? Is it soft tissue infection? Most importantly, though, structure, and that's what I think gets missed a lot, is that you can get a wound to heal sometimes by just putting someone in a hospital bed and doing some local care. But as soon as they start to walk again, it re-ulcerates, and we see it all the time. So what my sort of plan with these patients is, what can I do to the foot to address the structure so that the ulcer heals but also doesn't come back? And I'll show you kind of what I did with this case. So basically, I just went in, I did a 5th med head resection, which, is such a, it's an easy procedure. B, functionally, they don't lose a thing. Again, these patients are neuropathic anyhow, but functionally, there's not really an issue when you take the 5th med head out. And you can see how well that wound heals. So just by debriding the wound, removing the 5th met, 2 weeks, that's what it looks like. And that was, I think, 6 weeks. Completely healed, no problem. If you look at his x-ray, yeah, he's got a missing 5th met, but the toe actually looks probably better in terms of position because you de-rotated it. So these patients do great. And this was a patient that didn't listen either. He was a skier, and he was all over this thing, and he still healed very, very quickly. Submit one out, so we see these all the time. And the biggest problem with these is the sesamoid. So we were talking about sesamoids, I think, earlier, if we weren't, but they're basically 2 little piece structures that sit underneath the first met. And when you've got a diabetic neuropathic patient that's essentially walking on 2 marbles, the wound's not going to heal. So this wound was there for, months and months and months. They sent it to me. I debrided it. You see the incision on the inside. I took out the tibial sesamoid, put a graft on there. And again, this guy was healed in, I think that was 3 weeks, and that might have been 6 weeks. So a wound that had been there for 6 months or more is healed in about a month. But the graft that I put in there, I think, is part of it. The biggest reason is that sesamoid, though. And that's actually 3 weeks there. But if you look at this, this is a sesamoid axial. So this is looking at those 2 little pea-like structures. The tibial sesamoid in a lot of these cases, due to foot mechanics, is lower. See how that first or that inside sesamoid? So he's walking right on that marble. And they're big. I mean, when you take them out, they're a good chunk of bone. So it makes sense, just get that out of there, and these patients heal. And sesamoids, you don't need sesamoids in there. You can rebalance you can rebalance the tendons just by rerouting them through the capsule. And again, these patients do very, very well. Here's a stump wound. I mean, we see these. Well, I used to see these a lot. A case where my plan was to just do a double V to Y, essentially just do a skin biopsy technique, but I didn't have enough tissue. So what I did is I put a graft inside, and if you look at him, we'll get through it quick, but 3 days post-op, he's already starting to granulate and epithelialize. In 10 days, he looks great. We put a second graft on him in the office, which is what this video is, but we don't have time for that. And then he disappeared, so I don't know where he is. But initially, he looked great. Maybe he healed and he decided not to come back, or maybe it got worse. But so diabetic foot ulcers, again, I'd be remiss without just going over these statistics are staggering, and I'm sure you guys know these. But a quarter of patients with diabetes will have a foot ulcer, and those ulcers lead to 80% of all the non-traumatic amputations. Second amputation is required in 30% within 3 years, and 51% after 5 years. And Armstrong reported that 50% of patients requiring a BKA, now these are diabetic BKAs, don't make it past 5 years. Is that ridiculous or what? I mean, that's staggering, but that's reality, and that's why we got to be really diligent with taking care of these ulcers. And this last statement, I think, is crazy, that impact of diabetic ulcerations is greater burden to our healthcare system than cancer. I think the general public would be floored to hear that. I mean, they'd have no understanding that that's the case. All right, last one, which I think we're doing pretty good. Case 10, and this is a guy that I just recently saw, so this is something that happens more often than it should. 40-year-old diabetic male, neuropathic, poor glycemic control history, insidious onset, pain, edema, initial ER radiograph negative. He comes in and said, well, they took x-rays a month ago, it was fine. Worked up for infection, was sent to ID in Augusta, all these things, everything came back negative. Decided to send him to a foot specialist in Portland, and he noticed recently over the last few days the foot started to change shape, increased temp on exam, but again, palpable pedal pulses. Look at that foot. So that's a classic midfoot Charcot. I should have blew that up bigger for you to see, but that foot is entirely fragmented and dislocated in the midfoot. If that was a non-diabetic, if this wasn't a Charcot, that's a train wreck. That's trauma surgery, and that's a mess. But this is a diabetic neuropathic patient where with these, the answer is not to do surgery. That right now you want to just immobilize, and that's why I put that crow walker out. That's the most important thing when you identify this. And for this patient, unfortunately, it was a little too late, but once you see that red hot swollen foot, put him in a crow walker, get him off their foot, because that's what happens. It starts to deteriorate and rocker bottom very quickly. So that's looking at the lateral 6 months later, and he's actually done pretty well. But if you look at that's his initial on the left, and the whole midfoot is just, it's like a bomb went off in there. And you can see 6 months later it's stabilized a bit, certainly not perfect. And he keeps looking at the x-ray saying, Doc, don't you need to fix this? I'm like, I'm not touching that unless you end up with an ulcer, which is essentially, in my opinion, the only time you touch these. So what is Charcot? I mean, I can tell you what it is, and you guys probably know. You have to read this whole thing, but basically, it's neurotraumatic and it's vasodilatory, so you get a rush of blood flow to these bones. And I always tell patients to make it simple. It's like the sponge that sits on your sink. When it's dry, it's pretty hard. You can hit it. It's not going to bend or do anything. But you fill it with water, and it's all bendable, moldable. That's what happens to their foot bones. And they're neuropathic, so they don't even realize that it's all breaking and fragmenting. And you put those two things together, and again, it's a recipe for a disaster. So here's a foot that's already started to collapse but didn't ulcerate, and then they missed it, and then she ulcerated. So the ulcers are what drive you to this. And this is sort of another part of my practice that I haven't done a lot of lately, and I'm kind of happy because without residents, these are nightmares. But this is unfortunately what they need. Once they ulcerate, now you're dealing with, is it bone infection, is it Charcot, is it both? You've got to immobilize them, and the only way to do that and reconstruct at the same time is to put a frame on. So here's, again, this is a kind of classic Charcot where we were dealing with bone infection. So what you do is you debride, you remove, you pack the Stimulan bone graft, which is packed with, which you can mix with Vanco and any other antibiotic you want, and then you stabilize, so you put a frame on. And these frames, and the patients actually tolerate them relatively well, but there's a lot of complications that go along with them, and very important to keep them off their foot. But here you see this one went on to heal. The bone grafts that we use now all absorb, so you don't have to take it out. And that patient was in a crow walker for 6 months, but did go on to heal. So one last Charcot, real quick, I'll go through this. This is how severe they can get. And this is a case where it's multiple surgeries, back and forth with frames that we kind of de-rotate slowly to get them back in position. But here you see intraoperatively, Vilex was a company that myself and one of my other partners in Brunswick developed the frame for that company. That's why I keep seeing that Vilex. But that frame allowed that foot to get back into relatively neutral position. That was a large skin graft that we did laterally with a big wedge of tissue. So you'll see her pre and post. They're pretty good. So that's her that's her frame, and that's her post-op. Not perfect, but what we call shoeable, braceable, and that's a victory with these. You're never going to get it perfect, but that's a foot that stays attached to the lower leg. That's it. I think we did good. That's a good fish, right? That's a good fish. Yeah. Oh, that's my time. Any questions? We're almost out of time, but yeah. Yeah. I would say it's 80–85% because patients have asked that a lot, yeah. I mean, and I'm doing that as a last resort, so, you know, and I'm also doing that if the plantar fascia is tight. So oftentimes you get these patients that when you dorsiflex the hallux, there's not a tight fascial band. I'm not doing it in that case. It's more nerve related, I feel like, if there's not a tight band. If there's a tight band, that works very well. Yeah.
Thank you.
Sure.